Hello? There you go. Yeah, that works, yeah. It should be recording audio, yeah.
Yeah, so if we can put notes
and I'm
so that I have my notes down here. That would
go see. No problem.
Do you want to see it?
I'll be back.
Okay, great.
Do you want us to present a view?
Oh, there's two different
Yeah, but they said you had to have like two monitors.
No.
You don't? Okay.
This is your North Loop on Broadway.
Because when I tried to do that, it
29
wouldn't.
North Broadway. That's like
You know a trick.
No, that's why I said Swander.
Oh, okay. Yeah, it's
Chicago.
Okay.
It's on the battery, right?
I don't know.
Yeah, it's on the battery.
This is the one. This one downtown.
I mean, yeah, I just didn't want to like
50 Chicago is straight downtown. Yeah.
Okay, you can.
Yeah, it just needed to be extended.
Most downtown you could ever get.
So not by like.
Oh, wait, no, 50 East Chicago.
Just go check.
Is near North Loop.
So if you guys got another dog, would you just walk both of them in the morning?
Yeah, so she would have one to walk. She kind of wants a pug.
Oh, would she get up early with you?
I don't have notes on it.
Good. That works for you?
Yeah.
So she would think
Yeah, okay. No, that was perfect.
Alright, so let me fix
And
this.
if you print some too, that'll be great. But yeah, this will be better. We can get started.
You could just like, I know.
Yeah, it's worth it. So I just go and walk my dog.
Nailed that. Oh, with a cookbook?
Yeah, so you walk them at night and in the morning.
Yeah, and they love it.
Good, yeah.
She's like a really lazy
That
dog.
much activity.
And then like, of course, you just have like, you know, stuffed animals. You just close it on the apartment. They go crazy. But it's pretty big.
Dim the lights down from the back.
The textbook I use is like, it does a good job of like, okay, so you're going to use 1,800 plus shanks in this goes. So you can have all these bones. So use these bones to make this like specific bones. So if you can your own, you have to buy that.
Stop. Like PowerPoint's shut down.
Instead of taking it out of your trash, you're buying it. It's one of those things where it's like, okay, I'm going to cook. And I mark on my calendar. Something each one.
Because I usually get ultrasounds that they've done within the last few months, and like the only ones I've been getting are
Ready? All right, well, good morning. My name is Dr. Melanie McKean. I am a psychiatrist, actually out in the community, but I am also an adjunct assistant professor of psychiatry with the Department of Neurology and Psychiatry. I actually did a very similar talk a couple years ago for the MFM didactics, and I was invited back again, so thank you very much for that, and I look forward to speaking with you all today, giving you some background on psychiatric care during pregnancy and postpartum. I am happy to entertain questions throughout the talk, or it can be at the end. Either way, if you have questions throughout, please let me know. I have no financial relationships to disclose, and today, my goals, when you guys walk out today, is that hopefully you can just, just in general recognize common psychiatric presentations during pregnancy and the postpartum period, and perhaps even at least begin discussions with your patients on maybe potential treatments for the different symptoms that they're having, pharmacological and non-pharmacological, as well as advise women that are lactating as well. And then, consider, based upon your comfort level, maybe initiating certain sorts of treatments for psychiatric illnesses, or maybe identifying when to refer for specialized care. So most of you are probably very familiar with these definitions. I will be using them somewhat interchangeably throughout my talk, so I just want to kind of put that out there. And you are also probably very familiar with the FDA pregnancy categories for different medications. I'll be talking about that intermittently throughout the talk as well, and about what that kind of means in the setting of counseling women when they're considering pregnancy or during pregnancy and postpartum. So it's estimated that in the United States up to 50% of pregnancies are unplanned. And pregnancy, therefore, necessarily isn't always considered, at least at the onset, or at the time of finding out that you're pregnant, as a joyous occasion. Many women find it to be a significant time of self-deprecation, undermining their self-esteem, and with concerns of, quote-unquote, not being a good mother. And this is also in a time when new mental disorders may appear, and therefore there's certainly a need for increased support. And why is screening important? It's because women with a history of either major depressive disorder, bipolar disorder, or certainly even maybe more severe psychiatric illnesses are at a higher risk of relapse during the time of pregnancy and postpartum. And this is also, again, a high time sometimes for the onset of some illnesses. And then women who experience depression do not always seek adequate prenatal care, as we know, and that puts them at risk and puts their unborn child at risk as well. And this can also be due to concurrent, substance problems, alcohol, cigarette use, etc. Prenatal depression is associated with low birth weight, premature labor and delivery, and preeclampsia, and higher rates of expressed anxiety, somatic pain, and sleep difficulties in women are kind of positively correlated with depression, but often go unnoticed because a lot of times these things are considered to be kind of quote-unquote like typical things you would experience during pregnancy. So just going to kind of review, and you may or may not be aware, but earlier this year, our kind of manual for how we diagnose psychiatric illness, the DSM, a new version of it came out, so a new edition in May, called the DSM-5. So this talk is going to predominantly use DSM-4 criteria. That's still predominantly what we're using in practice. And for most of the things I'm going to be talking about, how you characterize something or diagnose something hasn't necessarily changed a whole lot, and I will identify those areas where perhaps it has. So first we'll talk about mood disorders. That's kind of where we'll put our main focus. Probably in popular culture, in the media, you hear the most about postpartum depression and mood disorders more so than some of the others, but I'll try to highlight, important aspects of other categories as well. So the depressive disorders, again, in DSM-5 have pretty much stayed about the same. There's still major depressive disorder. It's still diagnosed the same way. There's still dysthymia, or kind of a persistent, more milder depressive syndrome. And then kind of the catch-all category for things that don't quite meet criteria for either of those, which is depressive disorder not otherwise specified. In bipolar disorder, again, there's been a lot of talk that now it's more of a spectrum. The diagnoses are still there in the DSM-5. There's still bipolar 1, there's still bipolar 2, there's still kind of unspecified bipolar illness and hypothymia. And then certainly there's mood disorders that are induced by substance use and mood disorders that are secondary to general medical conditions. And this may not show up quite well, but just kind of wanted to review kind of how we diagnose a depressive episode or a manic episode. And again, depression is probably the more common thing that people are at least screening for, perhaps in practice. And that's going to be a period of time for a depressive episode of 2 weeks or more of feeling depressed. I often phrase that you feel sad, down. Not everybody knows maybe what depressed means when you say that, so you have to kind of give them several adjectives on kind of how they might be feeling during that time. Or anhedonia. And anhedonia is, I sometimes, when I ask patients if they feel that way, that's kind of like your kind of feeling, or that just feeling of not really being that motivated or really caring about very much. And so a depressive episode, you have to have had one or the other of those for at least a 2-week span of time for most days, most of the day. And then an addition of at least 4 of the other criteria, and that can include, some sleep disturbances. So sometimes people sleep too much, sometimes they have insomnia. If they have problems with interest level, finding joy in maybe the things that they used to, thoughts of guilt, hopelessness, worthlessness, energy, feeling fatigued, or just feeling like they don't have as much oomph. Again, a lot of times in pregnancy, a woman says she's not having as much energy, and it may just be kind of, that's, you're this far into your pregnancy, that's somewhat typical. So you have to consider that with all the other symptoms. Concentration difficulties, not being able to focus on tasks, retaining information as well as they are used to. Appetite changes, so sometimes that's decreased appetite, sometimes that's quote-unquote emotional eating or eating more. Sometimes I ask women, and this is maybe not necessarily in the setting of pregnancy, women or men, any dramatic changes in your weight, if you had a weight loss or weight gain, if you had to buy new clothes, those sorts of things. Psychomotor retardation or agitation, so some people feel like they're literally moving in slow motion, or that their body is very heavy. Thank you. Or that they are agitated, that they just can't sit still, or they're fidgeting a lot. And then certainly suicide, and we'll talk about that in a little bit more detail, and the importance of screening for that, and if they have a passive death wish or suicidal thoughts, and I'm happy to ask questions about screening for that, or how you kind of determine whether something's imminent or not. And then as far as a manic episode or a hypomanic episode, that's a period of time, and it depends. Sometimes it can just be a few days. In the cases of hypomania, it's generally a week or more. In the setting of mania, of an elevated state, usually I ask people, the classic sort of thought is that everybody's like euphoric and like super happy. You're on top of the world. You feel like, nothing can bring you down. But that's not always the case. Sometimes a manic or hypomanic episode can be extreme irritability. So it's either one of those, accompanied by decreased need for sleep. In hypomania, this is kind of surviving on maybe 3 or 4 hours a night. With mania, it could be little to no sleep at all for several days or weeks or more. Again, inflated self-esteem or grandiosity, easily distractible, going from task to task to task. So oftentimes you have to delineate, is this kind of ADD type symptoms, or is it like hypomania? Talking really fast, sometimes engaging in risky behavior, spending money you don't have, promiscuity, substance use in someone that generally wouldn't have been involved in any of those sorts of things. Some of these things can be more subtle. Hypomania is sometimes very hard to distinguish from just kind of an elevated, just a happy mood. And then certainly you hear a lot about postpartum blues, postpartum depression, and we'll also talk about postpartum psychosis. So postpartum blues, certainly the most common. 2.5 to 3/4 of new moms will experience some variation of postpartum blues. It generally comes on very soon postpartum, within, some women say even like within 24 hours, but certainly within the first few days postpartum, kind of peaks on about the 5th day, and should have resolved itself pretty much by around the 10th day. There may be some crying, increased anxiety, fatigue. Again, so many of these symptoms are very hard to just delineate from maybe quote-unquote typical symptoms you would expect someone to experience postpartum. The treatment for that is generally kind of support and reassurance. If there really is extreme difficulties with anxiety or with sleep, we might use a kind of a PRN to help with that. But we certainly wouldn't recommend, initiating an antidepressant or anything kind of on a scheduled basis. And if the symptoms last longer than 10 days, then you need to think a little bit more about, are we looking more at maybe a postpartum depression, which generally the DSM-4 would state, because they have major depressive disorder with postpartum onset, and they say it needs to occur within 4 weeks of birth. In my practice, and certainly with most of my colleagues, we recognize it can be postpartum depression if the onset is really any time close to a full year postpartum. Like if that's kind of their first ever major depressive episode, and you can kind of correlate it with pregnancy, then we consider it to be somewhat of a postpartum onset. Certainly they may have recurrent episodes after that. This can be anywhere from 15, newer data is even saying as many as 20 to 25% of women either during pregnancy or postpartum will experience a major depressive episode, so it's quite common. And it can, depends on the severity and whether they're breastfeeding or not, on kind of how you choose on whether to treat with a scheduled medication, with psychotherapy, etc., and we'll go into that in more detail throughout my talk. Postpartum psychosis, we'll talk about it now. I'll come back to it again a little bit later. This is certainly a very serious, this is considered a psychiatric emergency. It's very uncommon, 1 to 2 per 1,000, but it certainly gets a lot of press when something does happen, especially if there's an adverse problem like a mom commits suicide or infanticide. So it's very important to be screening. It's 100 times higher in women that have bipolar disorder, or if they've had a previous history of having an episode of postpartum psychosis. So it's very important to be screening women about their psychiatric history, and with prior pregnancies if they had any kind of worsening of symptoms or anything like this postpartum. They can have psychotic symptoms even if they've never had them before. So even if they have bipolar disorder or even other mood disorders and they've never had psychotic symptoms, they can present itself postpartum. It can be exacerbated by insomnia. They have rapid mood swings. And about 4% of the women that have an episode of postpartum psychosis do commit infanticide, which is why it is considered a psychiatric emergency and certainly must get the woman and their child safe. It's found to affect 74% of mothers with bipolar disorder and with a first-degree relative. So that's the other thing. We often screen women in their psychiatric history. Very important to also be screening them, mothers, maternal aunts, sisters. Did any of them have an episode of postpartum psychosis? Because that also elevates the risk. Schizophrenia, I'm not going to spend as much time on this, but just kind of important to know that there are several different psychotic disorders that we screen for, and those women are certainly at a heightened risk for having postpartum psychosis. so require very close monitoring throughout their pregnancies and postpartum. And then anxiety disorder. So of all the clusters that I've talked about so far, this one's had the most changes in the DSM-5. It used to be, just as it was on this slide, you had an umbrella for anxiety disorders, and everything listed there kind of fell underneath that. That has changed somewhat. Actually, obsessive compulsive disorder has been pulled out, and it's its own umbrella category now. And so hoarding has become kind of an official diagnosis. Body dysmorphic disorder falls under OCD. Things like hair pulling, skin picking, all those sorts of things are now under its own umbrella category. And the other thing that's changed is that, like post-traumatic stress disorder and acute stress disorder, there's a new umbrella term about trauma and stress-related disorders, and those fall under that as well. And postpartum, again, we hear a lot about postpartum depression, but actually any of the things that I've mentioned can have a postpartum onset or be triggered by something in pregnancy. So you can have postpartum anxiety syndromes, postpartum panic disorder, postpartum PTSD, and that can be from a traumatic delivery or traumatic events in your pregnancy. And then postpartum OCD, again, sometimes, especially with brand new first-time pregnancy mom, she's very hyper-focused about certain things. That can lend itself to an obsessive-compulsive quality, such as like if they have to change the diapers every certain amount of minutes, whether the infant has actually urinated or not, and other sorts of. And there can be a lot of intrusive thoughts that are very uncomfortable for a new mom to experience. Things like, what if I dropped my baby? Maybe they're in the kitchen and they're chopping onions, and the baby's sitting there and they're like, what if I took this knife and I did something? Very uncomfortable thoughts. Not homicidal intent, not suicidal intent, but just uncomfortable thoughts that come in their head, and that falls under kind of the umbrella of OCD. And then certainly eating disorders can be very problematic in the setting of, especially during pregnancy, but also can be with postpartum, and this is just kind of a review of the different forms of those. Binge eating disorder has now come out of underneath eating disorder NOS, and it is its own disorder as well. And then just to kind of highlight that there's lots of substance-related disorders, and we'll go through a few of these towards the end of my talk, but certainly important to be screening for that and determining the level of whether it's kind of an abuse or dependence issue or when they may need kind of formalized or specialized treatment. But for depression screening, we'll kind of go back to, again, maybe most commonly what you may be encountering. It's important to screen for symptoms as well as the history of depressive episodes. And this can be during pregnancy, postpartum, or even those not associated with pregnancy. So, always asking a woman if this is her, second, third, etc. pregnancy, like what did they experience during their first pregnancy? Did they have any depressive symptoms during that one or postpartum? Or if they had any depressive episodes, in their lifetime. And screening for that family history of psychiatric illness. So again, even if a woman has maybe experienced just unipolar depression, if she had a mom, aunt, other kind of close family member that's had an episode of postpartum psychosis or severe exacerbation of their mood disorder, very important to know. And we use there may be some scales that can be helpful. Some of these you may have heard of. There's the Edinburgh Postnatal Depression Scale. It can be administered both during pregnancy and postpartum. And then the Patient Health Questionnaire. So the Edinburgh Postnatal Questionnaire is a validated self-report and screening measure of depressive symptoms, both during kind of that peripartum or antenatal period of time and postpartum. And a score of 12 signifies possible depression and kind of prompts for further evaluation of that. And then what's very important is question number 10, kind of talks about suicide. The thought of harming myself has occurred to me, and said, like, yes, quite often, sometimes hardly ever or never. And so regardless of what they score on any of the rest of it, that's the most important question to kind of be focusing on. Sure.
Just ask, so I can't actually read the questions on there, but there's a scale that we're using in one of our perinatal centers that talks a lot, asks about things like sleep and weight change and things that are that would be obvious to say yes to in a pregnant woman. And so this one, does it use some of those kind of somatic? These questions I'll read them. I've been able to laugh and see the funny side of things. I've looked forward in enjoyment of things. I blame myself unnecessarily. I have been anxious and worried, scared, or panicky for no good reason. Feel better if you can. I felt sad or miserable. So this is mostly focusing on mood. This is mood symptoms versus all those other somatic symptoms. Because you're right, so hard with some of those, again, those criteria that I mentioned for a major depressive episode at least,
how much of that is your quote-unquote expected uncomfortableness or sleep problems, and how much of that is secondary to. So when I'm diagnosing someone, I certainly am counting those, but I try to hit the criteria with other ones if I can. But if not, then, maybe initially I have to say they have depressive disorder NOS, but I still would treat it because I treat the symptoms. And if they're depressed or anhedonic for 2 or more weeks, or it's impacting their life even if it hasn't yet reached the 2-week period of time, I'd probably recommend treatment of some kind. Again, we'll get into kind of how we decide what that might be, whether that would be medication or psychotherapy or a combo.
But this has been specifically validated?
Yes. Mm-hmm.
Actually, so as that inventory that we use, it was validated in pregnant women, and the score is actually different. We're deciding that they need further.
Right, but it's 2 pages instead of 1.
And it's not postpartum.
Right, but a lot of them also, a lot of the questions are, as I said, do focus on the somatic things that, I kind of have to, I have to look at more than just the score. If 2/3 of the score is coming out of, I don't sleep well, I've gained weight recently, and it's like, you're 38 weeks pregnant,
right.
You're not supposed to sleep well. Yes, hopefully you've gained some weight. There are things that, as opposed to, I'm sad all the time, I feel guilty, I blame myself.
I think like anything else, these rating scales are great as screening tools, but you're right, you really have to kind of look at the individualized person and how they're answering certain questions. And then this is a patient health questionnaire, so this is a more standardized, you can see this in like primary care settings. Again, this copy, when you get the slides, it may be a little bit easier to read it. And there's a suicide question at the bottom. Conveniently, they tend to put those like as the very last question. I don't know if that's to build up to it or if it's easy for you to recognize, but again, on this one, question number 9 is a suicide question. And then depending upon their score, again, kind of delineates the severity of depression. But again, even if everything else they rated minorly, but they're saying that they have suicidal thoughts, you would take action. So in 2009, in kind of an effort to, as they put it, address the maternal and neonatal risks of both depression and antidepressant exposure, and develop algorithms for periconceptual and antenatal management, representatives from the APA and ACOG and a consulting developmental pediatrician got together and formed this work group where they critically evaluated and summarized information, and then from that made some algorithms on how to treat depression and other mood disorders in pregnancy. And then this was published both in obstetrics and gynecology as well as general hospital psychiatry, and they're both in 2009. And so what they found was that at that point in time there hadn't been any studies to kind of link maternal depression in and of itself to congenital anomalies in infants. Neonates born to moms with a depressive disorder have an increased risk for irritability, less activity and alertness, fewer facial expressions compared to offsprings of moms who weren't experiencing depression. Greater than 80% of women are taking a dose of at least some sort of medication, and that was exclusive of vitamins from what they had done during pregnancy. And so the use of multiple medications was making it somewhat difficult for them to assess the impact of a single drug, such as an antidepressant, on maternal and fetal outcomes. And women taking an antidepressant were just in and of themselves more likely to be taking a medication for some other reason as well. As far as for tricyclic antidepressants, they found there was no association between the use of tricyclic antidepressants and structural malformations. For SSRIs, they found there was no increased rate of major or specific cardiac malformations in utero, with the exception of paroxetine, which at that time they were seeing some associations between it and cardiac defects, specifically ventricular outflow defects. And there was also some craniosinosis and phalloceal that were being found with some use of some of the SSRIs. When someone was taking an SSRI and a benzodiazepine, like Xanax or lorazepam, there was some increased, even elevated increased risk of the congenital heart defect, although most of that is considered to be related to use of the benzodiazepines, either kind of at the time of conception or in the first trimester. SSRIs are correlated with this kind of poor neonatal adaptation syndrome, which is a cluster of symptoms. It can kind of look like just irritability in general, but it can be some tachypnea, hypoglycemia, some temperature instability, irritability. About 15 to 30% of women taking SSRIs. And as we, again, go into kind of treatment algorithms and how, I make a determination or how I counsel women, I focus predominantly on that, if you're taking an SSRI during pregnancy, or at least in that third trimester, that may be what we're seeing, is there may be some period of time in that immediate postpartum period where your baby's a little bit more irritable, and there may be some of those kinds of symptoms we have to look for. They found that there was some increased risk of the persistent pulmonary hypertension of the newborn, or PPHN. I'll go over that a little bit later too, because there's been some kind of change in that theory as well. So how do you decide whether to treat or not to treat? So again, you kind of go through that criteria for depression, and you assess the severity. So we give qualifiers to major depressive episode of mild, moderate, or severe. And based upon that, I generally make recommendations. So certainly if it's mild depressive symptoms, I would probably advocate in the setting of pregnancy or early postpartum, especially if they're going to lactate, if we can, we would avoid scheduling an antidepressant medication, and that we would actually move more towards using individual psychotherapy type treatment, in particular their cognitive behavioral therapy, especially if they're experiencing a lot of anxiety type symptoms, or an interpersonal psychotherapy if it's more so impacting maybe their relationships with others. The best time to do this is preconception planning. Like ideally, if you can have a woman come into your office and kind of talk about her history of her symptoms, and you guys can plan for things, that's ideal. As we know, that generally isn't kind of how things work. And then, as I mentioned, the APA and ACOG presented some algorithms for management. So we'll just kind of go through each of these very quickly. So this is if you got to do that ideal kind of preconceptual planning. So contemplating pregnancy, but currently undergoing treatment for depression. So the first question this algorithm asks is the patient acutely suicidal or psychotic? Yes or no? And then if no, does the patient have moderate to severe symptoms? Yes or no? And it kind of works its way down. Did the patient start her antidepressant treatment less than 6 months ago? And so if it was no, does the patient have recurrent episodes of MDD? And then if that's still no, because unless there's a strong rationale that psychotherapy alone would be ineffective, or the patient feels she needs to continue medication, she's eligible for a trial off. So, the left side of this is kind of like the ideal situation. She's been in treatment, her symptoms are in remission, she's been taking her medication for at least 6 months. She would prefer to not take medication in the setting of conception, and so you could give a trial of tapering off the medication and see how they do. Now, if you go down more of the right side of this and you're starting to answer yes to some of these, certainly if it's the first question, if they're suicidal or psychotic, you probably wouldn't advocate for tapering off of medication, and you probably wouldn't advocate for them, moving forward with attempting to get pregnant at this point in time. But again, we don't always have that great preconception time. And then also it kind of goes through if they have remission of symptoms, how long they've been on their medicine. And even if they haven't been on their medicine per se for 6 weeks, if they're kind of in remission, they may still want to consider tapering off. But 6 months, usually when I'm starting an antidepressant in general, for someone whether they're pregnant or not, I tell them that's kind of like our minimum treatment time, is 6 months on a therapeutic dose with the goal of remission of symptoms. The next one was a patient who is already pregnant, but they start having a major depressive episode, and kind of how do you decide whether to treat or not? So again, first question is always actively suicidal or psychotic, and then if it's yes, aggressively treat the depression. No, is the patient willing to consider pharmacotherapy, and then go the yes or no route? And then was the patient treated with psychotherapy in the past? You kind of go that route, and was that kind of successful or not, or do they feel like that would be efficacious this time? Oftentimes, psychotherapy is limited based on time, sometimes time for the patient, like do they have time to engage in a weekly or probably at minimum every other week psychotherapy regimen, 1 hour per week. Cost, not all insurance plans cover, or they have a limit on how many visits, and if she's encountering her major depressive episode, in her first trimester, and she's looking at another 30 weeks of psychotherapy, some insurance companies limit how many visits, total psychiatric visits, you can have, or I should say maybe anything in the mental health realm. So if they're limited on visits, that's all their med management and psychotherapy visits. You can certainly appeal those kinds of things, but sometimes that's just too much headache for someone to want to go through. So they may sometimes lean towards wanting to try a medication versus that. Had other folks swing the other way, though. They really don't want to have to take a medication. If they're in that mild to moderate depressive category, that's certainly an option, and then we try to work out a really good plan for them. And then lastly, this is a woman with major depressive disorder, pregnant and currently taking antidepressants, and again, whether to continue treating them or not. And it's always important, I guess I should go back, it's always important to documentation. I mean, we hear about this all the time, but documenting a woman's choice. It's important to involve them in that, make sure that they feel like they're part of that decision. If they decline medication, documenting that. If they want to take medication, documenting that you've gone over all the risks, benefits, and alternatives, including the potential risks for some of the associations, at least, for some congenital anomalies, some of the persistent pulmonary hypertension of the newborn, the neonatal adaptation syndrome, that you've talked about all of those things and that they're aware of them. So then if you are moving more towards, starting an antidepressant, kind of how do you decide on what to choose? And again, that's going to be for your more moderate to severe depression. My rule of thumb is if they took an antidepressant in the past and it worked for them, then that would be the first medicine that I would go to. Because again, in pregnancy, we don't have as much wiggle room for kind of waiting to see if something new might work. And so if we know that there's something else that's going to work, I would recommend resuming that. If it's paroxetine, again, there's some elevated concern about it with cardiac malformations. Maybe we wouldn't do that if this was the preconception period or first trimester. If it was second or third, I probably would, because it's actually one of the most preferable for breastfeeding. But any of the other SSRIs, SNRIs, etc., if they were successful with them in the past, I'd probably go ahead and resume that. If they've never taken a medication before, then I would probably opt for one of the more tried and true SSRIs, one of that's been around the longest, that we know the most about. So if they are going to breastfeed, I would probably choose sertraline because it has a very low transmission rate in the breast milk. If not, I would either choose it or Prozac or fluoxetine. It has such a long half-life. That's one of the main reasons why it's not contraindicated, but not as preferred for breastfeeding. Again, if I have a woman who has done well on Prozac, though, and we know that it works for them, I'm gonna do Prozac. And then you may decrease or kind of taper down the dose. So there's kind of this window of time. If we cannot have them on the antidepressant in the kind of conception and the first trimester, that's great. That's not going to work for all women. Some women are going to know that their symptoms are going to relapse if they taper down their medication or they stop their medication. And then there's the third trimester leading up to delivery and increasing those risks for the neonatal adaptation syndrome or the persistent pulmonary hypertension of the newborn. And so ideally, if we can taper down to lower dosages, but again, every case is individualized.
Just a quick question about
Sure.
SSRIs. So, as far as if I remember correctly, it takes a while, a couple of weeks for it to actually work. So
Usually it's anywhere from 4 to 8 weeks. Every once in a while somebody says that they're responding at earlier than that, but generally it's going to be at least 4 weeks.
And so what do you do in the interim?
So in the interim, it depends on the severity. So I see my folks pretty frequently, especially early onset. So if it was a moderate to severe depression, we'd probably initiate the antidepressant. I would see them back within 2 to 3 weeks. I always tell them, if you're having side effects, call me right away, and we'll talk about alternatives. But I see them back within 2 to 3 weeks to see them face to face, see how they're doing. Some folks, for instance, there's someone that I'm seeing now. She just delivered a couple weeks ago, but I was seeing her weekly, even though we did initiate an antidepressant, because her symptoms were so severe. I mean, to the point she didn't want her baby anymore. She didn't have suicidal thoughts or homicidal thoughts, but she had thoughts of, as soon as I deliver this baby, I don't want I'm going to hand it to my husband, and that's going to be it. She was so depressed. There was a lot of other circumstances that had kind of led up to that, but I was seeing her very frequently so that I could monitor her symptoms, and then she was always able to contact me anytime.
And what about the increased risk, I'm correct about this, suicidal ideation at the very least, with SSRI initiation?
So that is up to age 24. Is where the kind of black box warning is, and that was recently increased from 22 to 24. So, I certainly mention it that every once in a while I have had people have increased suicidal thoughts regardless of their age at initiation of an antidepressant. But I feel mandated, like I have to say that to anyone who's 24 and under. So certainly, like younger moms, I would definitely be telling them about that. It depends on what those thoughts are. Generally the rule, kind of how we look at it is SSRIs are not going to create new kind of suicidal thoughts in someone who hasn't really had them before, but if there's been some sort of either kind of passive death wish or fleeting thoughts in the past, that has been found in some cases to be elevated with the onset of an SSRI, and some folks have actually, attempted suicide. So I certainly say, if you are finding yourself ruminating on it more, you find out that you may be in imminent risk, and if I have a parent there, if they're under 18, I have a parent there, then I say, these first few weeks are critical, we just need to kind of monitor things and make sure they're okay, and that we would stop the medicine, let it kind of wash out, and then try something different. But for people above the age of 24, I haven't really found that to be much of a risk. So persistent pulmonary hypertension of the newborn, multiple etiologies behind this, so it's not just the use of SSRIs or other antidepressants. Most common is meconium aspiration or other forms of lung injury. It's pretty rare. It affects 1.9 infants about out of every 1,000 births. And as you probably know, it's right to left shunting of blood through the ductus arteriosus and foraminal valley, leading to neonatal hypoxia. Can lead to lots of other comorbid symptoms, and if chronic and severe, can even lead to right heart failure. The absolute risk has been shown in some studies to be anywhere from 1 to 2 in 1,000 to 3 to 12 in 1,000 with those exposed to SSRIs after 20 weeks gestation. So not as much having to do with the first trimester exposure, but kind of later on. But none of the published studies have actually linked SSRIs with PPHN and leading to infant death. So I do try to reassure my moms that this is a rare syndrome that can happen with use of SSRIs. And even if it does happen, there has not been a report where any infant has died. Certainly it may lead to a stay in the NICU or something along that line, but that there's a lot of other reasons why someone might have PPHN other than that. Studies more recently have been kind of diminishing the association between SSRIs and PPHN anyway, so again, I still feel obligated to inform my moms about it, but I try to really minimize the risk for it, but I also don't want them to be completely shocked about it either. But again, this neonatal adaptation syndrome, that again is much more common. Anywhere from 1/4 to 1/3 of new babies may experience that if their moms are taking an SSRI in utero. I always kind of reassure mom that some of this has to do with, if they've ever kind of stopped their antidepressant cold turkey and they've experienced a discontinuation syndrome, that's kind of what their babies are experiencing postpartum, so just kind of not feeling quite as well. In adults, that can be like headaches, that can be a little bit of tachycardia, maybe increased anxiety, GI symptoms. Babies experience things a little bit differently. Sometimes if mom's going to continue to breastfeed, that exposure, there's still some exposure, and so it may actually be lessened in that situation. So which is riskier, though? Untreated depression or exposure to an SSRI? And this is a study, a prospective investigation with maternal assessments done at 20, 30, and 36 weeks and observing neonatal outcomes. And they had 3 different exposure groups. They had no SSRI exposure and no depression. And then they had SSRI exposure, either continuous or partial use throughout the pregnancy, or a diagnosis of a major depressive disorder, either continuous throughout the pregnancy or partial. And what they found was that partial SSRI exposure at some point, but with at least 1 full trimester without exposure, showed not as much significance, but it was mostly showing that if a woman had untreated depression or a more prolonged exposure to the SSRIs, both of those can lead to sometimes preterm delivery or low birth weight babies. So again, you have to kind of present the risks to mom, like what's more risky perhaps, mom being untreated and having a preterm delivery or low birth weight baby, or mom being treated and having potentially a preterm delivery or low birth weight baby. Neither one certainly is ideal, and again, if you can have patches of time during the pregnancy where they aren't taking an antidepressant, that's going to be the most ideal. But I always want a healthy mom. It's kind of sometimes liken it to like a mom with asthma, like we want mom breathing, she's going to be, the albuterol may not be the best medication also for your baby to be exposed to, but at least you're breathing and they're getting the oxygen. Again, with mom, an SSRI may not be the best medication for the unborn child to be exposed to, but if mom's able to have her mood fluctuations be more stable, have better coping skills, even if her infant does end up with one of these syndromes, she'll be able to cope with it a lot better. This is a chart, again, it's somewhat difficult to read. I'm happy to send it out individually. This was put together by the University of Illinois Chicago during my residency. I trained at Rush. I spent some time with UIC. This is the last time that they've updated, as far as I know, June 2009, and some of that's due to, certain people that were kind of organizing, developing this, not being there anymore. But this was the last one, and it kind of was their information for clinicians on how to kind of choose or what they found in the literature for different antidepressants, percentage of transmission in the breast milk, and advantages of using things during pregnancy. Had there been any teratogenicity found, and what maybe some side effects in breastfeeding infants. So we would oftentimes use this. So this is bupropion, citalopram, cypramine, Cymbalta or duloxetine, escitalopram, Prozac. So most studies have been done on Prozac than any other medication. And as we know, the more you study any drug, they're going to move down that chain of like A, B, C, D category. So there aren't any antidepressants that are anything better than a C. Everything is pregnancy category C. Paroxetine is currently a D. There's a medication called buspirone, which I'll talk about in a little bit, that we use to treat anxiety. That's a B. But again, just educating women on what those category levels mean, and that oftentimes it's because the longer something's been out, the more likelihood that there's going to be at least one case report of something happening, and it's going to bump it down to being a C. It's locked up. There we go. So management of bipolar disorder during pregnancy and postpartum. So generally with bipolar disorder, we aren't not talking as much about do we treat or do we not treat. It's more about what can we treat with that's going to be the safest. Onset of bipolar disorder kind of correlates or comes around the same time as most of your reproductive years. So most people are going to be diagnosed with bipolar disorder teens, 20s, maybe 30s. It's not generally a first-time diagnosis later in life. It might be that you get the diagnosis because it was undiagnosed and you kind of recognize there were symptoms. So this is a very common issue to have to deal with in reproductive psychiatry, treatment of bipolar disorder. Also to know if a woman's taking carbamazepine or Tegretol, that may decrease the efficacy of their oral contraceptive pills. So it's not a good medicine to be on and get pregnant, but it's also going to make it where their OCPs don't work quite as well. So you need to counsel women if they're taking that medicine about different options for birth control. Abrupt discontinuation, which often happens, of a mood stabilizer is probably one of the worst things that could happen. Because, again, pregnancy and postpartum, huge times for relapse of symptoms or worsening of symptoms for women with bipolar. And the last thing we want to do is just abruptly stop their medication. Again, considering that up to 50% of pregnancies are unplanned or women don't know they're pregnant early on, unfortunately, if the medicine that they're on is going to have had some sort of impact on development, it probably or may have already happened at the time that they find out that they're pregnant. And so the best course of action is to kind of slowly wean the medication and transition them to something that may be at least safer, and then kind of frequent ultrasounds and monitoring of that. And then informed discussions about the use of certain medications. You need to be able to assess, again, based on the severity of their illness, how much of that are they able to understand. Oftentimes having a family member come in with them to go over these and help them make those decisions may be prudent. Again, I would say of all the illnesses I treat, there's probably the greatest spectrum with bipolar disorder on a patient's capacity to make decisions. A lot of times with schizophrenia and psychotic disorders, unless they're really, really stable, we're often enlisting other people to kind of help them with making these kinds of decisions. Most of my folks with depressive disorder, unless it's really, really severe, again, they have the capacity to make decisions. Bipolar disorder runs the gamut. I mean, there's very, very functional people that have bipolar disorder, and there are people that have a very severe illness. And so this is kind of one of those, it's not as common as major depressive disorder, but it's still really important to recognize and refer if you feel like they need specialized treatment. And again, document your discussions, because the medications used to treat bipolar disorder are the ones most known to cause teratogenicity and other problems. This is just from an article in Current Psychiatry from a couple of years ago that kind of highlighted risks of discontinuing medications versus continuing them. So there's certainly congenital malformations and other problems that can happen with continuing certain medications, but the risks of relapse are quite stunning. And then postpartum mood in women with bipolar disorder, you don't have to have schizophrenia or psychotic illnesses, high risk for postpartum psychosis, suicide, infanticide, those sorts of things. And so this is a very busy slide. It kind of goes over a lot of the mood stabilizers, and so kind of their associations or risk of teratogenicity based upon where based upon in pregnancy. So Depakote, pretty much we do not recommend use of Depakote. Again, if we have the ideal situation where we can do preconceptual counseling, we would recommend transitioning to a different mood stabilizer before getting pregnant. It has such a significant association with congenital malformations, and it says risk increase at doses greater than 800 milligrams a day. I mean, pretty much everyone on Depakote's on a much higher dose than 800 milligrams a day. But even the other medications like carbamazepine or trileptal, which is a pretty close sister drug to Tegretol, all of those have increased risk of teratogenicity. Lithium's kind of come around a little bit. So we actually are a little bit more in favor of continuing lithium than some of the other medications. Again, how do we make that decision? If a woman has been tried on many different mood stabilizers and lithium is the drug that is what keeps them stable, then we might recommend that they continue on that. We might try to lower the dose. But the Epstein's anomaly, about 0.05 or 0.1% of infants exposed to lithium, which is about 10 to 20 times greater than the average population's risk for Epstein's anomaly, but overall it's a very low absolute risk. And so explaining that and educating mom about that, and then doing high-resolution ultrasounds early on in pregnancy and repeating that if needed. So we aren't quite as prohibitive about the use of lithium, at least as much as it used to be. A lot of studies have actually had initially shown the risk as high as 11%, and then more recently more so like 2.8% of the Epstein's anomaly. Lamotrigine may be preferable to lithium if we can transition them to that, although there's still a high rate of some congenital malformations, including cleft lip and cleft palate. This is 1 to 2% with dosages less than 200 milligrams a day. That dose or that risk increases significantly greater than 200 milligrams a day. And just to give you kind of a perspective, so the max dose of lamotrigine, and again, this is neurologist's concern and our concern because it's often used for seizures as well. My average dose of Lamictal is anywhere from 150 to 250 milligrams, probably for mostly bipolar 2. It's not necessarily the best drug for bipolar 1, but if someone has mostly depressive episodes and some hypomania, then lamotrigine is actually a pretty excellent drug for that. But it just kind of depends on where they kind of fall or where they would be stable. For bipolar 1, though, oftentimes they're going to be on one of these medications for stability, and therefore we may be considering transitioning them sometimes to some of the atypical antipsychotics. Seroquel was the preference, again, at the UIC clinic that I worked at. There was also some use of risperidone and olanzapine. So the rate of congenital malformations with these drugs have been found anywhere from 1 to 4%, but that's about consistent with the general population rate. And so considering these kind of more direct correlations with some of the mood stabilizers, if it's an option, if a woman can be stabilized with one of these medicines, that might be preferable as well. There was another algorithm put out by one of the authors that had been involved in the APA-ACOG. This was more recent. This was 2011, on just kind of going through actually mania or history of bipolar disorder and deciding on how to treat. So again, does the patient have current mania or history of bipolar, yes or no? And if it's yes, do they have psychotic symptoms? And then based upon that, if it's yes, then you're going to continue treatment. They put with a typical antipsychotic. Again, the typicals have been around a lot longer, been studied a lot more, and a lot of folks would actually feel perhaps more comfortable with using something like haloperidol or Prolixin or one of the older antipsychotics to treat, because again, they've been around longer. You know more what the risks are versus some of the newer medications. We may not necessarily know what the risks are. Haloperidol may not be as great of an agent for kind of ongoing bipolar symptoms, perhaps a Seroquel that is at least FDA approved to treat bipolar disorder as well. So everyone's going to be a little bit, there's not a standard of care, I guess I should say, on exactly the things that we would use. It really depends, again, on individual woman's symptoms and the clinician that you're working with. ECT in pregnancy, so this is certainly validated and approved treatment regimen for women. It's generally felt to be pretty safe, and it's very effective. It can work very quickly. Again, a lot of women are not going to, with their first major depressive episode, want to consider anything along this line, and we probably wouldn't recommend that. But if there's a lot of conflicting factors, either if it's very severe depression, life-threatening kind of situations, suicidal or homicidal ideation, if we're needing a very quick response, and especially if they're having to be hospitalized for the severity of their depression, this might actually be an option in that case, because again, our antidepressants don't really start kind of kicking in if we've chosen the right one until several weeks. We may not always have several weeks. And it's sometimes preferred, again, to the rapidity of the response. Sometimes you have to modify the technique for pregnant women, so certainly they have to have a pelvic exam. You need to make sure there's not any cervical dilatation or any vaginal bleeding, because in that setting you wouldn't want to do ECT. And then you usually do also set up monitoring for contractions as well as a fetal heart monitor in those settings as well. And you may need to, depending upon how far along they are in their pregnancy, even displace their uterus to the left when you're doing the procedure. So we'll kind of move into anxiety. So you have to, again, assess the degree of impairment. I've found that especially like postpartum onset of anxiety disorders is becoming more and more common, and it can be very extreme. This can be panic attacks. This can be just kind of generalized anxiety, the OCD symptoms that I mentioned earlier. During the conception period and early pregnancy, we do not recommend the use of benzodiazepines. Most of them are category D, some of them are category X. If they've been taking them long term, though, again, you can't just stop it because there is an elevated risk for having a seizure if they've been taking it for a long time. So you at least would need to taper. But that can be done still fairly quickly. They may experience some more of discontinuation or some mild withdrawal symptoms, but should kind of impede them actually having a withdrawal seizure. For mild to moderate exercise, all those things there that I recommend. You guys probably recommend these things during pregnancy anyway. Getting exercise, good sleep hygiene, relaxation strategies. For mild to moderate, we might recommend individual psychotherapy, in particular kind of cognitive behavioral therapy. Buspirone is a medication that's approved to treat generalized anxiety disorder. It does not treat panic attacks, though. But it is category B. It's about the only medication that in my psychiatric armamentarium that is category B. And so sometimes we do utilize that. And then if they're having more severe generalized anxiety, lots of panic attacks or obsessive compulsive, then we consider initiating an antidepressant. This is also a workbook that I often recommend to my patients, especially if they are not wanting, actually whether or not they're wanting to initiate medication. It's very practical. It takes a lot of cognitive behavioral strategies. It's very easy to read, has a lot of different charts and stuff for them to fill out. It has a chapter on relaxation exercises, and so goes over diaphragmatic breathing, goes over guided imagery, goes over progressive muscle relaxation, and gives them examples of all of the different anxiety disorders related to either pregnancy concerns or postpartum. Talks a lot about those intrusive thoughts, too, for the obsessive compulsive symptoms. And it's actually pretty affordable. I think it's like under $20 on Amazon, so it's a pretty affordable thing. Again, postpartum psychosis, I won't spend a lot of time on this. Psychiatric emergency. Should rule out metabolic causes because a lot of these symptoms can present similarly to delirium or infections, especially if a woman has no history whatsoever of any psychiatric symptoms and then all of a sudden is acting very unusual or odd. Please, rule out that there's any medical reason behind that. Although you're going to be treating the agitation and some of those symptoms with antipsychotics, you're going to treat the symptoms as well. Aggressive treatment of insomnia. So that can sometimes be one of the keys to keeping a woman from having a manic episode or even going into postpartum psychotic episode. And that has to be discussed during pregnancy. A lot of the medications a woman is taking, especially if she has bipolar disorder or a psychotic illness, are not going to be that compatible with breastfeeding. And so kind of making a plan with her and her family about how the feeding of the infant is going to happen on overnights and trying to keep mom with a good sleep hygiene and having help for those things. And perhaps, if they are wanting to breastfeed, kind of figuring out what may be the safest medicines for them to take. But similar to risks for extrapyramidal symptoms with the use of antipsychotics yourself, that would be a risk for the infant having those symptoms as well. So oftentimes we don't recommend breastfeeding if they're going to need to be on one of the antipsychotics. Actually, Depakote has been found to have a very minimal transmission rate in the breast milk, and so in the postpartum setting, if a woman's taking valproic acid, we do generally say it's okay to breastfeed. Close supervision, again, monitoring for suicidal and homicidal ideation, ECT for refractory cases, and psychoeducation of the patient and their family on what to kind of look for. There's a great review article by an author named Seaman. The reference is at the end of my talk. If you happen to encounter a patient that has schizophrenia, really talking about, again, preconceptual planning, assessing for intimate partner violence, thinking about financial resources, education on nutrition, assessing for comorbid nicotine use or other substance use, which is very common in the schizophrenic community, and access to primary care, and adjusting their medications, because certain medications may be downregulated based upon blood volumes and other medications they may be taking. So that's actually across the board with a lot of the medications that we use while we're talking about weaning dosages prior to delivery. Some of that's already happening on its own because of the increased blood volume, and someone may have worsening symptoms because of that even if they've been stable on a dose. This is just talking about the pregnancy categories. Again, there's no antidepressants that are anything better than a C, and paroxetine and nortriptyline are Ds, and then this is the antipsychotic category. Clozapine's actually a B. But if you recall anything from psychiatric care, clozapine's one of the last line of what we would use for psychotic symptoms. It's usually after a patient has failed multiple other antipsychotics, requires extensive monitoring, especially early on of blood counts due to agranulocytosis. Lurasidone, which is Latuda, pretty new antipsychotic on the market. You know, they're running around telling everybody how they're pregnancy category B. Again, probably once they've been out for a little bit longer, they're going to make their way down to the C. We haven't found it to be a very efficacious thus far. I don't use it very much. A lot of people come to me, they've been started on Latuda actually for bipolar disorder. It's not FDA approved for that, but there's a lot of talks around where they're talking about how they're working on getting an FDA approval for that. So it's not necessarily very efficacious thus far antipsychotic. These three down here, though, they're newer. What they're hopeful is that to find an efficacious antipsychotic that doesn't lead to quite as many of the metabolic side effects. You've got kind of these older, maybe more efficacious, well, these are all efficacious, but a lot of these newer ones that don't have as many of the extrapyramidal symptoms but have more of the metabolic. So they're trying to get us there, but we haven't found too much success with any of these new ones yet. And then just quickly talking about breastfeeding, if you're having to counsel women on lactation, there's some websites you can go to, LactMed. If you put that into Google or it goes to like ToxNet, you can put in like any medication and it gives you, again, kind of the summary of its use during lactation, drug levels, effects on breastfed infants, you know, and you kind of scroll down and can see, and it's updated intermittently. It's maybe not always be like up to date. This is actually from a two-part series that I published earlier this year on pregnancy, psychiatric care in pregnancy and postpartum. Just kind of wanted to highlight that while there are pregnancy categories, there's also lactation risk categories, L1 through L5. They somewhat correlate with the A through X, as far as L1 is the safest and L5 is kind of contraindicated. So there's actually a book that's put out pretty much every year by, I believe it's Haynes is the author. It's called Lactation in Mother's Milk, and it has every medication on the market and has your pregnancy category risk and your lactation risk category and talks about the percentages of transmission, and so it's a really handy resource to have when women have questions about the medications they're taking, whether they're psychiatric medications or others. And then as far as substance abuse, you know, that certainly can be a huge problem. It's always important to be screening women. Alcohol use in particular is more common than we may realize, as far as for especially heavy episodic drinking or heavy use, so it's important to be screening women for their kind of preconception alcohol intake and then monitoring that postpartum. There are reporting requirements related to alcohol and drug use within each state, and we are legally mandated to test and report in some states, and Missouri is one of those. 17 states consider substance abuse during pregnancy to be child abuse, and 3 states can actually consider it grounds for civil commitment. We aren't one of those. 15 states require healthcare professionals to report suspected prenatal drug use, and 4 states require testing if it's suspected. There are only, unfortunately, 18 states that have either created or funded treatment programs targeted to pregnant women, and Missouri used to be one of those, but unfortunately, in 2012, that program is no longer existent. 10 states do provide pregnant women with priority access, and Missouri is one of those, and 4 states prohibit publicly funded drug treatment programs to discriminate against pregnant women, and Missouri is one of those 4 states. So this is a report that's put out by the Guttmacher Institute like every year. It's updated every October 1st, and so you can see again, it's not considered child abuse in the state of Missouri or grounds for civil commitment, and we don't mandate reporting or testing. We do have pregnant women are given priority for programs, and you can't discriminate against them, which is great. There's screening resources. You've heard of probably the CAGE. This is very similar to that. It's called the TACE, Tolerance, Annoyed, Cut Down, Eye Opener. It's often preferred by, or was put out by ACOG as a kind of a preferred screening tool. What they found is a lot of women minimize their alcohol use even more so than men, and a lot of that, it's hypothesized, has to do with concern that they're going to be reported, or that they are going to lose, their child if they let you know how much they're drinking. It's very important to, educate women on, we really are just kind of wanting to get a sense of how much you're drinking. We want to help you due to the risks of ongoing alcohol use in pregnancy, and, do everything we can to minimize or have you be completely abstinent. And give them all the education behind that and kind of reassure them that there are treatment programs available, that it's not a direct, you're going to be reported and your child's going to get taken away, sort of, because that's one of the biggest concerns why women don't report. Opiate dependence, these medications can be used to treat that. They're both category C's. Nicotine dependence, again, the total amount, if you use a nicotine supplementation, the nicotine exposure is much less with nicotine replacement therapy than with ongoing smoking. So again, kind of assessing your risks and benefits of using that. You can use bupropion or Wellbutrin for treatment as well if there's no history of any seizures or bulimia history. There's no really current opinion on varenicline or Chantix and if it's safe in pregnancy. So at this point in time, it's kind of felt to avoid use of it at this time. And then kind of lastly, just helping to deal with stigma, helping your patients to kind of, understand that postpartum depression at least is very common, but mood disorders and anxiety disorders are very common in pregnancy and postpartum. There's a lot of support out there. There's a lot of options for treatment. It does not always have to be medication. And then with realistic expectations, also letting them know not everything that goes on with pregnancy and motherhood is quote-unquote blissful or wonderful, that it's okay to not enjoy every moment of it, but that, there are certain clusters of symptoms, and if it's impacting their everyday functioning, that may need treatment, and that it is treatable, that it's a disease process like high blood pressure or diabetes or seizures or asthma, and that, we can treat them and optimize their daily functioning. It's also important, as you think about, you guys are seeing your patients very frequently during pregnancy, but oftentimes as soon as they have the baby, your connection with them diminishes quite a bit. And the pediatrician starts to become the main point of contact. So it's important to have a collaborative approach, get that connection set up, as early as possible, and getting the pediatrician on board. If she's seeing mom every 2 to 4 weeks, having her kind of check in with mom and how she's doing. There's some websites out there that you can refer your patients to. This is the Postpartum Support. International Network has a lot of resources for patients and links to different kind of online groups and sometimes even some local things. Mother to Mother, unfortunately, is closing. It was out of the Maplewood area. It's going to be closing soon. It was a 24/7 support line for women. I actually referred one of my patients to it within the last couple months, and she got on there, and they just posted on September 16th that due to lack of funding, they're actually going to be closing soon, so that's unfortunate. Mass General's website, great for clinicians, great for patients too, always has up-to-date dialogue about different studies being put out there, so I encourage you guys to check out that website too. And just in summary, depression and other psychiatric illnesses is very common. It's essential to be screening because you guys are oftentimes the first line for a lot of women if they haven't had any connection to the mental health community before pregnancy. Avoiding abrupt discontinuation of medications if they're taking things that you're uncomfortable with, getting them linked to psychiatric follow-up as soon as possible, and maybe starting slow weaning of things that are somewhat contraindicated, but not abruptly stopping them. Presenting women with all potential options, whether that's medication, psychotherapy, groups, family therapy, and then co-management between you all, a mental health professional, and their pediatrician. Those are my references. So I'm happy to entertain any questions. I know we're running a little bit over time, so thank you. Oh, it's just some beautiful graphic I found on Google, and I like to put it up and just
Thank
questions.
you. Great talk. Question for you on the questionnaires. A lot of times, if our patients sort of fall in the category of the mild depression, do you reuse the same questionnaire, and how frequently do you use the questionnaire again to see if they've sort of escalated up in categories? And is there a questionnaire for bipolar disorders?
There's not something great yet, like a one-page sort of thing. I mean, there are some questionnaires out there for bipolar symptoms, but they're much more exhaustive. Probably wouldn't be something practical to be using on a regular basis. You kind of take that initial score on the, whether you do the Edinburgh Post-Depression Scale or even give them a Beck Depression Inventory, which is a 2-page. But take that initial score. If that initial score is pretty low, so 12 is kind of the mark of concerning depressive symptoms. So certainly if it would be anything, I would say above like 8 or 9, I would be repeating that. Perhaps even it depends on how frequently they're coming. If it's early on in pregnancy and they're only coming once a month, then it might be prudent to do it once a month. If they're getting to the every 2 week or every 1 week visits, again, it depends. Like if the score is staying pretty stable at maybe it's 8 or 9, but it's certainly still not hitting 12. If that first score is 12 or up, then I would say definitely repeat screening, but you may be referring them directly from that initial survey anyway. But if it's like 3, I would probably say you could do it every few months, something along that line. There's no kind of standard of, and generally I'm not using that in my practice as a scale. I'm asking them all of those kinds of questions just face to face versus using the rating scale. Any other questions? Yeah.
In the buspirone, how anxiety is probably what I find I have to talk to patients about the most. And how do you use that medication?
So that medication is initiated at 7.5. I initiated at 7.5 milligrams twice a day, and you can increase it by 5 milligrams every week. And so it comes in a 7.5 milligram tab. It also comes in 10s and 15s and 30s. And so I usually give them a week of 7.5 twice daily, and then I give them 10s. And I have them go to 10 twice daily, and then sometimes we do that for a week, sometimes 2 weeks. And then I have them increase either the morning or the nighttime to 15 by taking 1.5 10s. So they go from 15 to 20 to 25. And the average treatment dose is around 30, and the max dose they can take is 60. I don't know if I've ever had anybody even close to 60. Usually around 30 seems to do it. For some people, even 20. That's why I kind of maybe get them up to that 10 twice a day, maybe leave them there for. But it also takes up to 4 weeks to have efficacy. What I often use is diphenhydramine if it doesn't make them too sleepy. And I tell them get the tablets or get the liquid form in the pediatric section, and you can adjust that really well. If you get the gel caps in the adult section, it's 25 or 50s, and you can't do much with that. But you can get a tab or get a liquid, and you can take even 6.25 or 12.5 milligrams, and that might be enough to kind of take a little bit of the edge off. Some people smell diphenhydramine and they're sleepy, though. So if that happens, it's great for the nighttime, like insomnia, like sit up, worry. Hydroxyzine is another medication that I use. It is category C, and I do tell them that, although there's no direct correlations with problems. But I prefer one of those, certainly over the use of any benzodiazepines. I have had women that, if they've had benzos and they've been using benzos, it's hard for, and I don't try to sell Benadryl or hydroxyzine as a benzo. It's not. And if they've used a benzo, they're going to take some hydroxyzine or diphenhydramine, and they're going to be like, it doesn't work for me at all. I certainly never advocate use of it in the first trimester. Some maybe very limited or minimal, especially like if they know they're going to have a huge panic attack if they go on a flight, then I'll say, 0.25 or 0.5 milligrams of Xanax you can take to go on that flight. It's kind of like alcohol. There's no minimum dose that we can ever say is okay, but we kind of all know that one glass of wine in the whole 40 weeks of pregnancy is probably not going to lead to a problem, and probably 1 or 2 doses of a benzo in the second or third trimester isn't either, but nobody's going to put that on a paper.
Doses, would you mind giving us a quick update on Seroquel as well? We've got a lot of patients in clinic that can't make it to you, and we end up starting them.
So I would start them on like a 20. If they are completely med naive, especially, I would start them on like a 50 milligram tab and have them take half of it to start out, because it can be extremely sedating. People that get really, really used to it, it's not. But even like little elderly folks, like 12.5 milligrams can be enough to kind of help with some mood stabilization and some sleep. So I would prescribe 50s because it's easy to titrate. And economic-wise, because it's not a cheap medicine either. So if they can get 50s, and then you have them start with a half, do that for a few nights, then maybe go up to a whole, then 1.5, and you just kind of like titrate them up. It's going to be based on kind of symptom management. I mean, some people, if it's kind of just some mild bipolar, mood fluctuations, they may do okay with anywhere from 100, 150 milligrams of Seroquel. The doses for psychosis are much higher. I mean, that can be anywhere from 600 to 800 milligrams. You would be, even though there may be a lag time of getting them to a psychiatrist, you would not be treating them at those high doses. But I would just start that and titrate. And if they're able to, again, it depends on their ability to kind of manage their medications. You know, I try to give my patients as much freedom as they can with things like that, and say, don't give them finite, like, this many for this many days. If they need that, though, then I do that, and I would say 25 milligrams for 7 days, and then 50. But some of them I say, try it for 3 to 5 days, and then based upon how you're doing, increase to the higher dose. So you kind of have to judge their ability to do that on how strict instructions you give them. Yes?
What are any tips for dealing with people on chronic use of try to cut it down?
So I often try to liken the benzos to opiates, and we try to, diazepam is a long-acting, which is somewhat favorable. A lot of times you're getting people on chronic alprazolam, and then I often switch them to something more like either Librium or the diazepam or clonazepam, and then start weaning. So you wean by about 10% of the dose every 1 to 2 weeks based upon how they can tolerate the withdrawal symptoms. So if they're taking, 10 milligrams of diazepam, then you might be able to do that with 2.5 milligram, maybe 2 milligram increments every couple of weeks. That's a little bit more than, but it's a 10 to 20% every 1 to 2 weeks. Oftentimes I'm having people come to me on 3 to 4 milligrams of alprazolam, and then that dose. The other thing to find is a benzodiazepine calculator, similar to your opiate calculators, because knowing kind of what's the equivalent of Xanax to lorazepam to clonazepam, and I mean, I know it, but sometimes you have to punch it in, but half a milligram of Xanax equals half a milligram of clonazepam equals 1 milligram of lorazepam equals 5 of Valium. And so I use that to kind of convert them to a longer acting agent, and then weaning by the 10 to 20% every 1 to 2 weeks. And then again, if they're able to do it, I let them kind of gauge whether that's every 1 week or 2 weeks, because as I tell them early on, we're only taking away 10% of your dose. But if we keep taking away that amount, eventually that becomes a quarter of your dose or half of your dose or a certain amount of that. And so sometimes we have to slow down the taper as it gets further on. I've had a lot of people on just maybe 1 milligram of clonazepam, and that's one of the hardest things. Sometimes if they're on just that half a milligram or 1 milligram of something at night, started as a sleep aid, getting them off of that. And I often have to transition them to something like Librium, because 25 milligrams of Librium equals half a milligram of clonazepam or 5 of Valium, but it can come in 5s, and so I can break that into very small pieces of the clonazepam or the alprazolam. That's what I do. I'm happy to answer any other questions you guys have and stick around for a little bit. I have cards too if anybody wants, if anybody needs a referral base. I'm out in Chesterfield, with the St. Louis Behavioral Medicine Institute. So, and my kind of forte, or what I like to treat, is women's mental health, preconceptual counseling, anxiety and depressive disorders during pregnancy and postpartum. So happy to see folks, or have you guys email me if you have questions. Okay, thank you.
For women, when they come by in this, some of them don't want to be on SSRIs until the second or third trimester. Some don't want to be on it until the postpartum phase, especially those that have had history of postpartum psychosis. Is there a magic number you put in before they deliver that you put them on it, or just prophylactically?
I would say, I would certainly recommend, you strongly you give them the data and strongly recommend to them that they consider. If you can get them through the first
neonatal
trimester.
adaptation, how long does it take for someone to get sensitized?
What they found is that if if they didn't take the SSRI at all in the 3rd trimester, then probably that would